Welcome, everybody. I'm sorry we're a few minutes late, but hope you're ready for some dessert. We're having a very informal question answer time by popular demand from those of you that were part of our Come to the Table Learning series. I'm Jenny McLaurin and help to run this for the National Association of Community Health Centers. I'm in Ferndale, Washington, which is a little town, and Comcast has decided to work on the internet today. So I'm on my phone, going back and forth and hoping that I get everything that's needed, but feel free if you have a hand up or something and you don't get noticed to unmute and just step in. I know that we have Adrian back with us and Brenda, we have Rick, Jessica Wallace. Am I missing any other folks who were community health center speakers for us? Sonia Fuqua. Is there anybody else that I missed? You can speak up if so.
Haley Ringwood will be here soon. She just finished with patients, so she'll log on in a minute.
Okay, great. Well, you can ask your questions. We'd like to be interactive, so if you can turn on your cameras, that's awesome. So we can see your faces. And this is just back by popular demand. I know I'm gonna tip it off. I know one of the questions for Rick was around two things, billing and coding, and there's been a lot of that on the AAP listserv also. And then on any pharmacology use in children who are in the upper ends on the obesity spectrum. So Rick, you want to help us with those questions?
Sure, I'll be happy to try to help with those. Again, I'm Rick Reifenberg. I'm a MedPeds physician. I'm at HealthNet, which is an FQHC in Indianapolis. We have about 9 health centers here. So I'm the chief medical officer here too, but in my clinical time, I have the joy of doing a weight management program. And I've been doing it for about 10 years now. So I have a registered dietitian that I work with, and we do it half a day a week. So that's the program that I have. And when I presented before, I did talk somewhat about billing and coding, and then I've noticed on the listserv, a lot of questions and things have come up about billing and coding. So and I found it interesting to read through that as well. So that's one area I saw some good information that was being presented there, and I can just share my real world experience. So as an FQHC in our particular practice, about 70% of my visits are Medicaid, and of the remaining 30%, about 15% are self-pay, and about 15% are commercial insurance, regular kinds that you would expect. So that's the basis that I'm in Indiana. So if there's unique things there, I can't speak to that for your state. But what I can tell you is from my experience, I always, when I code, I typically have the obesity diagnosis in there, and based on the class, and then I have all supporting comorbidities. I noticed in the listserv there were some different methods that people were using, and some maybe in their state using obesity may would attract attention or have some billing issues associated with that. I have never had that. I do feel like it is the correct technical diagnosis, and so that's usually my first diagnosis. And then it's rare that that's the only diagnosis I use, because almost everybody has something else, whether it's elevated blood pressure or hypertension, prediabetes, dyslipidemia. And often, especially in the adult patients, there's often orthopedic things related to it, osteoarthritis or knee or back pain, et cetera. So it's rare that there isn't more that I could put. Also, I often will put in, what would be more behavioral health diagnoses that maybe come up during our visits. And so I will absolutely include those as well. So the typical visit for me is probably going to have anywhere from 2 to 4 diagnoses, and the ones that I just mentioned. And then I'm doing typical, anywhere from, it's usually 99213 or 99214, unless they're new patients. And you can code, of course, based on the medical decision-making complexity. You can also do it by time. In our case, for a long time, as part of our 330 grant, we have had the dietitian's salary covered that way. So that's been a nice thing. And for most of you, I assume you can't bill specifically for your dietitian's time. Now, I saw on the listserv some people were, making sure that they, incorporated in their documentation that this was a joint visit, including dietitian, and then, billing based on time. And, usually being in that, this particular person was typically billing 99214 or 99215. And, based on the time, the joint time of everybody's along with the documentation. And I could see how you could do that, and depending, again, what your payer mix is. I mean, for me, we have a, wrap payment that's associated with 70% of my visits. So I want the coding to be accurate, but I'm certainly not making an effort to code higher because I'm going to get paid more at that time, because it's going to end up being the same cost either way. And so I always, I have a lot of residents that I work with. I mean, my mantra to them is always code accurately. Don't try to think about how much money you're going to get out of something, et cetera. You have to code it correctly. So by using that technique, I can't recall the last time I've had anything denied or turned down or that I've had a problem with. So let me just I'll stop there and just see, based on billing and coding, anybody have specific questions or experiences maybe that you want to share?
So I don't see questions in the chat, but Liz, if you do, let me know. And this is being recorded. So for those that aren't able to listen, I think right now they'll appreciate having the information recorded. Brenda, how about you and Haley? What is your experience in and the revenue side of this?
Hi there, this is Haley. Sorry I'm late. I just finished with my last patient of the day, a teenager who was really worried about her weight, and we had a really long conversation about weight and health. Anyway, Jessica Wallace would probably be the better person to tell us about billing and coding, but we tend in our Healthy Lifestyles clinic to, the dietitians can't bill, but the behavioral health providers can, and the medical providers can, the health coaches can't. So I generally end up billing like a level 3 visit and saying, they met with a dietitian for X amount of time, and I reinforce the education provided by them. But then, bill correctly based on my medical decision making, and did I order labs or did I order meds or things like that. And then Brenda bills for behavioral health visits.
I do, yeah. I usually bill. I don't know if any behavioral health people are on this call, but I usually bill H codes. So an H0025, which is good for the Medicaid population because it's reimbursed and there's no session limit on it. And then for diagnosis, I usually put counseling on health promotion and disease prevention.
That's great. Renee has a question. What about services other than E&M services? Do you use H and B codes for behavior visits? I'm not sure what E&M.
So that's the code, sorry. That's the codes that Richard was referring to. Those are E&M codes that healthcare providers can bill. So they call it a qualified health provider, nurse practitioners, PAs, and physicians. And so thinking about you guys sort of described already, RD services, it sounds pretty typical in FQs. What about health and behavior codes? So Brenda, you just described a code that you use. Do you not use health and behavior codes to address those visits?
I do. So the H0025 code is a health and behavior change code.
Okay.
And then the H0002 code is like a behavioral health screening code that I may use occasionally, but generally it's the H0025 health behavior change one.
Okay.
Yeah.
I just have referred to them as different codes before, not H codes, but that's great to know.
Yeah. And that might be different just because I'm a psychologist and billing on the behavioral health side. I don't know how it works for the medical providers.
No, but that's great. Thank you. And what about programs? Is anybody having challenges like sort of billing for like, I mean, Jessica has really great examples about billing for programs. Do other people use those sort of same approaches? Haley, I really like your approach around kind of overseeing services.
So we do, Jessica's our boss, so we do what she says. But for our MEND program, for example, the real intervention is the class, and the kids are playing outside and cooking and learning about nutrition for 2 hours. And then they meet with me for 5 minutes and I'm like, what goals do you want to set? I make sure, are they due for labs, that kind of stuff. And then that's how the program is sustainable, is that I built those visits, in which the actual intervention that they're benefiting from is not me, but I'm the one who sustains the program by billing.
You don't bill it like a brief visit. I mean, you say 5 minutes, but you bill it as a level 3, you said, right? Which would seem right to me.
Well,
'Cause
actually, for the MEND visits, so our with the class, I usually bill those a level 2. I do 2 different things. So the healthy lifestyle clinic that we do is like individual clinic visits in which they talk to the dietitian or the behavioral health provider or the health coach. Those I bill as usually a level 3, and I spend slightly more time on those. The class where they're just like mostly playing and then I'm talking to them quickly, I usually do bill level 2 for those, because I'm providing a little bit less intervention. I can do more if they're due for labs or something like that, then sometimes I'll bill a little more if we had a longer discussion about the actual medical problem and did some things about it.
And that's every 2 weeks for you, for your own input there, or is it every week?
Every week.
Oh, okay. So that, yeah.
Every week for the class. For the Healthy Lifestyles Clinic, patients usually come once a month or so, but for the class, it's every week. Brenda and I both bill visits every week for that.
So that makes sense.
Visit.
Yeah. In terms of like getting an audit or something, that seems reasonable to me.
Mm-hmm.
Adrian, how about at your place? You're in Florida, right?
Yeah, so I'm in Miami, Florida, and we do a program similar to MEND, but it's more kind of geared to our population. But it's actually 2 sessions a week, one with me, I'm a PA, and one with a nutritionist. So I actually bill every other week for my sessions, and I make it a level 3. So I make sure I talk to each patient individually, and ours are actually online. And so through Zoom, the nurse, before our visit even starts, they call and they get their blood pressure and their weight so that we can have their vitals set before we even have the class, the group medical visit.
Thank you. So another question, it just flew out of my head. So, sorry, I see something else in the chat.
Hey, Jenny, while you're thinking of that question, I'm going to add one other thing for the billing and coding part. You know, when I was looking at the listserv, and there were a lot of entries put in there from people about essentially just trying to find a way, how can I make this work, you know, where we're not losing money, or how can, you know, I help support the fact that we have a dietitian or something. So and somebody commented on this, and I realized it's something that I'm already doing anyway, but and that was the one who was, you know, putting more detailed documentation and, you know, coding at the higher level. I guess what the point that I'll add for myself is that because I work, you know, I've worked with this same dietitian for 10 years now. We just work really well together. And so, you know, I see patients from 7:30 to noon on that day, and we have 14 slots. It's a lot of patients. Now, between no shows and things, we usually don't have that many, but, you know, we're usually shooting for 10 to 14. between the medical assistant or nurse who's working with us and gathering information, and they're even doing some education as well. They spend a lot of time with the dietitian and then time with me. The dietitian actually documents in my note, like the dietary history and the things that she does. They're in my note, so it actually, that's already done for me. When I go in, I might edit a little bit. So think of it as like extending me, like, because I'm the one billing. I can see more patients, but we still do a good job because everybody's spending time with them. And then just so she has track of the people she's really seeing, even though she's put it in my note, and there's a thing in my note talking about the dietitian seeing the patient. She also has a separate note for herself. Again, that's just easy for her to know how many visits she had the whole year, but those are non-billable. But so by utilizing that, by all the other help, I'm able to see a lot more patients, and we can bill for all of those. So just, again, if you're trying to make this work, that could, if you're doing that consistently and having those numbers up like that, it really could potentially help pay for that dietitian as well. So we'll just mention that.
Thank you, Rick. I remember what it was. A lot of people were interested in outcome data and how I know that you folks who've initially been in MEND and then are in commit have particular outcome data that you're looking at. But one of the emphases in our sessions were not to focus on weight so much, and especially in the short term, even BMI change is is a longer term process. So what are the outcome measures that your teams really pay attention to, and how have they helped sustain your program when we all know that it takes a lot of effort to do what you're doing? And anyone who wants to start with that. Adrian, maybe I'll pick on you and ask you.
Okay, so we do several measures. First, we do order labs, and that consists of a lipid panel, a CMP, and a hemoglobin A1C. And so the program I do is a 10-week program. So we do it at the first visit, and then we do it again at the last visit after 10 weeks. And then we do 2 surveys. And one is the Zeller survey, and the other one's the 5210 survey. One's for the parents, and it just shows us how many fruits and vegetables they're eating, how much water they're drinking. And the other one's for the kids, the Zeller, and it tells us how they feel about themselves, essentially. And we use all of those. So I'm with kids, they're 7 to 12, so it's harder to use their BMI or weight for anything because they're growing.
Right.
But the one outcome I have found consistently is that hemoglobin A1C is usually going down from that first visit to the last visit. Even if they were not in pre-diabetes yet, which a lot of them are, it's still downtrending. And the other ones, the Zeller, I found kids start to have more confidence in themselves, and so they start to like themselves more. And I found when the kids have confidence in themselves and like themselves, they take care of themselves. So those would be 2 of the things I've noticed.
That's fantastic. And in our current national mental health crisis, that's fantastic. I mean, that's an outcome worth pursuing. So Brenda, were you going to say something? I saw you thinking.
No, I just think that's great. Looking at well-being, quality of life kind of stuff. Jessica can probably better field this one, but I think we're shifting more to like lab improvements and how kids feel about themselves, and also just your relationship with food and access to healthy food options. But I don't know what Haley and Jessica would add to that.
Yeah, Jessica.
I can weigh in a little bit here too, because this kind of speaks to, I think, how you move from research into like, what is it like to do this work on the ground and in your individual setting. And so, the original MEND curriculum, which is packaged, has the training, all that stuff, has a very robust evaluation component to it. When we were originally kind of grant funded, and this is speaking about both the NAC commit program as well as our experience at Denver Health, the MEND program evaluation is almost 200 questions. And it's a lot about health behaviors. It is a lot of weight-related quality of life. It kind of took all these validated scales and put them together. So you were able to say, you know, yes, this program still works. Is it still effective? And we did that for a while in Denver Health, you know, but it's very burdensome. It's not fun for patients. You know, they're tricky surveys. It takes a lot of time away from actual the power of the groups. And so what we've done at Denver Health, and now it's kind of mirrored in the NAC work with Commit, is really look at those 200 questions and say, what are the ones that matter the most? And the things that we do want to follow for quality patient care, you know, to ensure enough kind of success and effectiveness in the program, but reduce all of the burden. And so from there, the questionnaires shrunk down to about 2 pages, and using, I think, and Renee might be able to correct me, but I think the sizing me up and sizing us up were some of the examples of how those surveys ended out. But then once, you know, if you think about it, MEND and programs like it were often made to be implemented in a community setting. And that's very different when you go in the health center, because these are our patients. And so you do have opportunities long-term to be able to, within the EMR, track things like weight and blood pressure and labs without a whole lot of extra effort if you have a way to flag them as being part of this program. And so CDC helped us do some analysis of a couple years of MEND data that did show change in BMI trajectory and change in systolic and diastolic blood pressure for these kids who participated. And then, you know, you have the level of effectiveness, but then you can also, again, continue to tweak what it looks like that you measure. You know, we built flow sheets into our EMR. We're not the greatest at keeping track of them, especially when everything went virtual. So, but I think it's important to recognize that there can be a shift, there can and should be a shift away from all that data gathering into, you know, what's actually feasible to do long-term and what gives you the most information to really help patients.
Yeah, and our participants, their question wasn't so much about the MEND part, but really about in the FQHC setting, what outcomes are you gathering that are making a difference to particularly sustain your program and to show that it matters. And so I think that well-being one is really important because we didn't want to focus on weight per se. So Renee, I know you had something in the chat about SDOH, and we've had asking if folks are screening for it. And it was interesting. Yesterday I listened, I don't know how many of you listened. There was a UDS mapper, food insecurity and health centers, and they were teaching people how to map on with Feeding America by county level data. Can tell you where the greatest food hunger is and food insecurity in the country, and then how to use that and integrate it into your UDS mapper. And this would be like, I think at a PCA level or healthcare network level would be fabulous for them to do, to find food pantries, food banks, food programs, and pin them next to the health in the health center that's in the region of food insecurity. It was really cool because the Feeding America has all the resources, and then the UDS mapper has the health center. So it was a way to integrate those into one map. But their data was that 1 in 8 people now experience food insecurity. So that's higher than it was a couple of years ago. And that the highest rates of food insecurity are in Black populations, single-headed households, and children. So that is also a huge overlap with our families that we're caring for. So the question we had was how many of you were actually screening for SDOH, and that would be more than, you know, just food insecurity. But I don't know how many of you have the Prepare tool or how many of you are using that in your programs. Haley?
Yeah, at Denver Health, we have social determinants of health screening that has just recently, it was sort of piloted at a couple of clinics, and then now it's been rolled out to all of the FQHCs at Denver Health. For kids, it's once a year that the families fill out. And now I don't know the name. Jessica might know the name of what actual questionnaire it is, but once a year they fill it out. It talks about housing, utilities, transportation, food, safety. There might be more. Those are the main ones. And so that's in like well child check visits. And then in our Healthy Lifestyles Clinic and Mend visits, we ask primarily about food insecurity and just kind of, I feel like we get to know the families really well and just hear more like comprehensive stories of their lives and can help connect to resources when needed. We also have a cool partnership with something called Denver Food Rescue, where we have like boxes of food that we give out every Tuesday. And so we've been trying to make some of those partnerships within our organization and then connecting families with those. So that's what we do.
Thanks. How about you, Rick? And then Sonia, I haven't called on you. I know that in Mississippi, you had told me that you're doing all sorts of things.
Yeah, I'll just say briefly that we use the Prepare tool now, not in our program, but at my organization. And again, kind of more like what Haley was saying, that it would be kind of like an annual thing that we're trying to do. We're actually trying to have social workers do it as a way to get that data in there. It does take a little while to fill out that particular form. And then, in our program, it's just kind of as we get to know, there's always a significant time we spend in the social history part, the first visit, and try to learn, what barriers, if any, and to kind of go at it that way. So that's our experience.
Hey everybody, Sonia from the Community Health Center Association of Mississippi. And again, I'm from the association. I am not from a particular FQHC. So we have varied things that are going on. We do have some health centers that are utilizing the Prepare tool specifically, but all of our health centers are collecting SDOH data one way or another. The differences are how they respond to the data that they do collect. Is it just going into the EHR, or is somebody actually looking at it and then making a response? With that being said, we've spoken a lot about men, and I know this is about childhood obesity. A couple of the health centers that have been involved with our men programs, one of them established a community garden and actually let the children in the community come out and help dig and got involved in the garden. And the children really liked seeing their work come to fruition, and people could just come and get what they wanted. It was a small garden, but they did implement that. Jenny, that's one of the health centers that actually participated in your pilot a few years back when we were asking the food insecurity questions. Another one of our health centers that's involved in men has a collaboration with, or they're dovetailing their programs, shall we say. One of their programs has a collaboration with one of the local farms here in Mississippi, and they give out food boxes to the participants in the program. We do have several health centers that work with the Mississippi Food Network, and they have established food pantries on site at their community health centers. So we do have varied things that are going on. Unfortunately, it's not across the board, but I know you've heard this before. Once you've seen one FQHC, you've seen one FQHC. So what's happening is varied among our health centers, but I just want to say that we do have food insecurity response efforts that we are involved in, and we're pleased with what we do see.
Thank you so much for that and for joining. Renee, on the webinar yesterday, they said it was something like 77% of health centers are collecting SDOH information.
Yeah.
So I don't know if your question.
I was just curious about that. I also wanted to follow up on the question around outcome data. I think Jessica sort of was leading toward this, that sort of moving away from research, collecting data for purposes outside of patient value we can sort of view it with a new lens, right? Like what's most important to my patients. And so if you think about it that way, it could be that I don't know, improvement in physical activity is usually the first thing that can improve with weight loss. You know, sort of looking at heart rate recovery or something like that. Look at how amazing your body is functioning. Quality of life is another, decrease in bullying, those kinds of things. Like, you know, what is the most important for your patient for that value? The things that I find pretty important for systems level are implementation measures. So I think this idea of BMI has really caught on as like, well, that's what we care about the most. That's an individual level outcome, right? But isn't it potentially more important to know that we got 3 cohorts through this year and for 3 years, right? Rather than 1 kid lost weight. Or you know, looking at sustainability, looking at like adoption. We have all of these providers who are now delivering improved care. So sort of spread and scale or reach, right? So if we can think about it and like back up to the systems level outcomes, maybe we can start to think about and push our leadership to really, this is me speaking as myself, not as representing anybody, but like really push our systems to start to think about outside of individual outcomes. Like, what are the most important things we want of these programs? And we might argue that, like, you know, having a program running for 10 years is pretty darn amazing in this world. You know, so how do we sort of shift our view around individuals versus systems? So that's my pitch on outcomes.
I think another thing that's come up again and again and again, it came up in the people that wanted more, and it came up last year, it came up this year, is around the motivational interviewing and how to speak with families about weight issues without either the provider just cringing and feeling terrible, or without bringing on stigma or bias, and just to make it a comfortable, healthy part of primary care. And that alone is pretty huge as a systems level thing. And by extension, motivational interviewing works for everything. So I think that part of the work is really important to track in terms of outcomes. And I don't know if anybody is tracking provider, actually hate the word provider, clinician effects of participating in these kinds of things, whether they feel more comfortable, more positive in engaging families around weight issues. But is anybody who's on the call today, or any of you actually looking at clinician satisfaction or outcomes? Because it is it's one of those like, depressing things for most people, I think. So that's an area for the future, but I can see that in this horrible workforce adversity that we're in, and difficulty in just keeping staff at levels that we need to care for our families, that that would be potentially a positive workforce thing to track and measure. And on the other hand, I can also see that programs could get axed because of staff needs. So, you know, I think it's going to be important to measure whatever we can that shows lasting value. So any other questions, or those were the questions that came through to me from the chats previously. And I think Sarah's on, and Jessica, I don't know if you saw any other questions that came through.
No, nothing yet.
Okay, well, since this is being recorded, our wonderful guests, would you like to offer any words of advice for those who are going to tune in and listen and try to get a few more crumbs out of this?
I would just say patience, because it does take a long time. I think for us, we've tried to do this online program for a few years now, and it's finally feeling smooth. And that's like after like 7 sessions. So patience is very important, and don't, I don't know, lose your goal, the goal vision.
Thank you. And can I ask, are you going to continue it online even if?
Yes. Oh, sorry.
Okay.
Keep
Yeah.
going. Oh,
No.
yes. So we have, we're actually, today is our first day. We're doing kind of like a little summer boot camp. So anybody that's kind of graduated our program, whatever age they are, we're bringing them all back in, and it's just 4 weeks. And it's kind of more in depth, a review, but also giving them more details, kind of feeding off of that foundation they already built in that first 10 weeks. So we're really excited to try that for the first time today.
That's great. Congratulations.
Thank you.
Brenda or Haley, do you have any advice?
I would say, gosh, just the thing that we've been talking about and thinking about and working on so much recently is around weight stigma. And for me as a provider, I'm challenging myself to say, do I have to talk about weight today? Or can I talk about health behaviors and praise healthy behaviors and set goals for change that are going to help this patient be healthier without telling them that they're overweight or that they're obese or at risk of harming them in some important way? And so I don't know the right answer, but that's what I've been working on. And I think it'd be interesting for other clinicians to challenge themselves just to think about that. Do I have to frame this around weight, or can I open this with this broader picture of health behaviors and staying healthy, and have the same effect without the harm in doing it that way? So that's what I'm individually working on, and that our team is talking a lot about.
Love it.
Yeah, I'd echo that. And I think we're having a lot of fun with groups. I think the clinicians on the team and the patients are having fun with groups and teaching patients some of those hands-on skills and being in the room with them with their food and their curiosity and all of that stuff. And then community partnerships, I think, are really fun. So it feels like step one, help the person in front of you, regardless of their body size. You know, those groups are inclusive for the child that has a higher BMI and their sibling that's within a normal BMI. You know, it's for everybody that wants to learn about healthy habits. Yeah, so step one, just help the first person in front of you. Step two, have a good time, like have fun while you're doing this work.
Love it.
Yeah.
I agree with, just to echo, Brenda's been so instrumental in starting all of these cooking demos that we've been doing, and cooking classes, and families cooking in their own homes while like working with the chef on a Zoom screen with the ingredients we gave them, and just helping people have fun making delicious food that happens to also be nutritious. I just like can't overemphasize what value that's provided lately.
And really changing a whole family too. You're not just focusing on one individual. So
yeah, one of my favorite patient quotes in our last cooking demo, we did like little English muffin pizzas where they could pick their own ingredients. And one of the kids was like, hey, is this like a Lunchable? Which is like so reflective of our patients and how busy their families are, and like parents that often work 2 jobs, and Lunchables are the convenient, fast answer.
And they're fun. Kids like them.
Fun. Yeah. Yeah, and you can like engineer your own little pizza. Like that is really fun. So I think teaching those skills, and it's really.
That's great. And answering yes instead of, ooh. I didn't let my children have Lunchables, and they were always just so upset about it. So, Rick, how about you? What do you want to leave people with?
You know, what I think about the work that we're talking about doing, it's reflective of what FQHCs do well, which is integrated care with a whole bunch of specialties, right? Everything from the advice we give may well help, you know, what the dentist is also trying to help with the patient, et cetera. You know, I think it's fair to say, if any practice, if you said whether you see just kids or kids and adults, is there a need for this type of care for our patients? You know, there's an overwhelming, of course, you know, it's a huge need. And that in order to meet that need, I think having a few well-trained, experienced people who can be leaders can be huge for a bigger practice. But that having been said, everybody can do their part. And in the, again, what is primary care? If we're doing it right, it should be a lot of, preventative care and really healthy lifestyle, which goes into what, everybody was talking about. And then finally, I'll just share, Jenny, you asked about, like, we don't do anything to specifically measure, like, provider engagement or involvement in this, in this program per se, since I'm the main one doing it. Although I've had a couple other providers in our group who wanted to, who I've spent some time with, and they're kind of doing some mini things on their own. And one of the most gratifying things that I heard from them, and they came to me and said, I want to do this because I see this need. And a few of them had said, when I worked with patients just on some of the things we're talking about today, and they made healthy changes in their lifestyle, and they came back and the patient was so excited. And, maybe whether it was their A1C, whether it was their weight, whether it was their blood pressure, whatever, the thing they were working on, improved. They're like, that was like the most, I treat all kinds of diseases, but like, that was like the most gratifying thing I did this year with patients. Like they, so they really saw the value in that, probably because it touches so many things in that patient's life, including their own self-esteem, et cetera. So yeah, I think we're doing an important service here, and having more of it and doing it well is a great thing.
Thank you. Sonia, at a network level, what would be your call to others who are in your sort of arena?
Just like to say that I did not know I was on program for this meeting today, and Jenny just called me out. Anywho, but
yeah, that's
from
true.
this, go ahead.
That's true.
Yeah, teach me to show up. Anyway, from the association level, I just like to say that, we appreciate the effort that it takes to implement childhood weight management initiatives, programs, or just do the work that health centers do within the confines of their space. And we are supportive as well as we can be. As with the MEN program and the CORD 2.0 program that we also have with a couple of our health centers, when we see an opportunity, we want to encourage participation and support them in their implementation. It is much needed. And we've seen the changes, I know you all have, particularly during COVID, the impact that it has had on childhood obesity and adults as well. You just look around the room and you can see the difference that it has made. So I think this is much needed. I like the collaborative efforts that are taking place, organizations that find that they are walking in the same direction. So let us work together to get to a common goal. And we appreciate the collaborations that we have established here in Mississippi, working with children organizations and working with churches as well to impact obesity. And then also there's the opportunity for us to work across states, just as we're doing here on this call, so that we are not all reinventing the wheel, and we can share seamlessly and steal shamelessly.
There you go. Good last words.
Thank you.
Thank you all for joining. This was something that folks asked for, and I know your time is precious. So thank you all for stepping out of your everyday roles and going into a little bit deeper detail for folks. And until some other time, wish you well.
Bye, everybody.
Bye.